Thank you for joining us. It's my pleasure to introduce Dr. Denise Geiger. Dr. Geiger is the Director of Laboratory Services and Clinical Trials at John T. Mather Memorial Hospital in Port Jefferson, New York. She oversees the selection and implementation of new lab technology and performance metrics for a lab with a test volume of over 2.4 million tests a year and serves as the principal investigator for clinical trials. She received her Master of Health Science from State University of New York at Stony Brook and her doctorate in biomedical science from Pacific Western University in Brentwood, California. She has received numerous awards and is the author of more than 70 clinical journal articles and book chapters and is an experienced speaker. Her topic today is leveraging technology to change laboratory dynamics, transition from volume to high-value patient outcomes. So please welcome Dr. Geiger.
Thank you, Kim. It's my pleasure to be with you, and thank you to Mark for warming up the audience for me. And in the short time that we're here together today, we are going to talk about how we can leverage technology to have better patient outcomes as we move from fee-for-service to a value-based purchase system. As part of my disclosure, I am receiving an honorarium for the talk today. And so in this brief time that we're together, I'd like to discuss how we can leverage new technology to improve quality and patient outcomes. How can we measure direct impact of our laboratory tests on organizational performance? And then we'll examine the value of laboratory information and how the lab can contribute to performance-driven healthcare. So we need to actually talk about lab information because lab information is our product. And it's said that upwards of 70 to 80% of medical decisions that are made by healthcare professionals originates from the laboratory. So it's really important for us to be able to deliver rapid results, quick diagnosis, and these are two of the key pieces in looking at a value-added system. The other two pieces that we look at are that we're able to provide high-quality care and that we're having cost savings or cost avoidance, as well as then improving satisfaction for our physicians and our patients. And so if we look at making the case for laboratory diagnostic information, we know that it's an essential element of the healthcare system. We know that laboratory medicine is integral to medical risk and decision making. We also know that that information is pivotal to preventing or improving diseases by prevention, treatment, diagnosis, and better management of diseases. We know also that the laboratories, tests, and information also help us to have actionable information, thereby changing the course of disease and decreasing the burden of the disease. We know that today, if we just look at a 10-year period from 2005, in 2005 we spent $2 trillion on healthcare. 10 years later, it's up 49%. In spite of Obamacare, the number is projected to be $3.2 trillion, or $10,000 per person in 2005. That's 18% of our gross domestic product, and by 2021 it's expected to be 21% of our gross domestic product. Did you know that labs are only 3% of that total healthcare cost? So I think that laboratory medicine and the tests that we provide are certainly an integral component and partner in the healthcare delivery system. Unfortunately, it's under-recognized, and that's one of the things that we need to do. As laboratorians, we need to increase the awareness of the value that the laboratory brings. And it's so inexpensive and considered how much of the other cost comes from other departments and other sites of healthcare. So what I'd like to say, and for you to take home, is that the laboratory, we can add a test with the goal to improve patient outcomes while reducing the cost of that episode, of that event of their care. So labs can spend more money but contribute to thousands of dollars or millions of dollars in cost savings or cost avoidance. And so, as I said, that's like the third tenet of value added. So for our lab, this is our strategic plan, and I don't think my strategic plan is any different than your strategic plan. I'm sure we all want to maintain or improve our quality levels. We want to free up valuable time and resources by identifying the biggest productivity barriers that we have. So we want to remove the roadblocks, the bottlenecks, so that we can streamline our process. We want to eliminate any duplicate efforts, but we don't want to remove our safeguards. And what we really want is to have a proactive environment rather than a reactive environment. I know I don't like it if a vice president comes to me with an idea. I'd rather be going to him with an idea and having him buying into my vision. We want to leverage critical intelligence to drive these medical decisions that we're making. And one of the ways we can do that is by providing rapid turnaround time, because we increase our efficiency by doing that, and we have faster, rapid diagnosis. We want to create that real-time knowledge, and we want to assure patient safety with a patient-centric approach. So you need to ask yourself, does your process leave you and your staff tired? I don't want to find any of my staff members laying down and sleeping because they're so exhausted. And so technology today can help us tremendously. I think that two of the major breakthroughs that we've encountered recently have certainly been automation and auto-validation. Those are two key components that have synergy, that leverage the technology so that we can be more efficient and we can have faster turnaround times and we can have quicker diagnosis and we can save money or avoid costs and have patient satisfaction and physician satisfaction. So here's two people in my laboratory, and this is how our laboratory looks today. And what I want to tell you is that we can have clinical impact. Just recently, this year in March, we upgraded our Sysmex with an upgrade from an XN2000 to an XN3000, the slide maker stainer. And what we've been able to do now is also leverage the WAM system so that we have better auto validation. Our rules are in there for our patients. And what we've been able to do is to decrease our turnaround time on a CBC by 56%. 14 minutes for a CBC today. 14 minutes only. Everything is now being handled by our rules on the systems. If it needs a slide to be made, it'll reflex it right to the slide maker stainer for us. And here are two of our medical technologists. And you can see they're pretty happy. Now, basically, if we take it away from them, if they don't have it, they're crying. They say, I want that back. And so let's talk about leveraging the middleware for information management, because that's really what's running in the background in order to allow us to do other tasks and to allow a CBC to be released in 14 minutes or less. And what we have here is it's combined into 4 different areas: instrument management, task management, and host connectivity for us. So the WAM is the brain that takes these major tasks, and then it breaks it down and it does other things for us. Under instrument management, we have information coming from our LIS system. It's downloading our samples. It's doing reagent tracking for us, lot numbers. We've managed to leverage for the first time our rules engine and put rules and validated those rules for our patient population. And now we have pages and pages of rules that are embedded into the WAM system, allowing it to happen in the background automatically. It's handling our QC for us. It's also an event log. It allows us to keep track of what's happening in real time. If we talk about task management, it provides our reference ranges. It provides delta checks for us so that we're able to quickly check those samples that are left behind. I would say that now upwards of 80% of our work is auto-validated, and the rest of the work is then reviewed by a medical technologist. And most of that work is in the oncology space. We also have the ability, as I said, to reflex using the slide maker stainer to do that automatically. And we also have rerun criteria for critical values. As far as the results are concerned, if anything needs to be done by a medical technologist because it's abnormal and didn't pass our rules on auto-validation, it allows a medical technologist to do what they need to do prior to releasing it to our LIS system. We're able to upload those results to the hospital system. And what I'd like to say to you is that in the course of time, and on the y-axis over here, we have the number of workstations we had, actually going back to 1993, and then looking here to 2013, and on the other y-axis we have the number of total volume of tests that we've had, and our total volume has gone up tremendously. And what you can see here is that the number of workstations, because we've tried to leverage technology in every discipline within the laboratory, we've been able to decrease from 13 workstations to 5 workstations today. And all of this work is being done in our laboratory has less than 2,000 square feet of space. So we're doing 2.4 million tests in that space. So consolidation with technology and leveraging it together for synergy has given us less workstations, down to 5, while the work volume has increased tremendously, over 100%. Something else I'd like to talk to you about are some of the advanced clinical parameters that are available on the XN3000. And I'd like to talk a moment about reticulocyte hemoglobin. This particular analyte is a direct cellular measurement of the incorporation of iron into hemoglobin in the developing red cell. It's able to provide rapid information for screening for iron deficiency, as well as being able to monitor changes for patients who have severe iron deficiency and undergoing treatment. It also is much more sensitive because it is a direct cellular measurement than the indirect chemical measurements we have today that typically we associate with iron identification and management. Our basic chemistry tests of iron, iron binding capacity, transferrin, and ferritin, those kinds of tests. And also, this marker now has provided us with new insights into erythropoiesis and allows us to detect those patients who are non-responders to treatment with using erythropoietin-stimulating agents like Neupogen and such. These people typically have functional iron deficiency, which means they have adequate iron stores, but they can't mobilize the iron to use it effectively. And so, let's take the reticulocyte hemoglobin test. And I want to let you know that the value of this test is really unquestionable because it has the ability to save lives, manage people's iron deficiency much more better, and we're going to save dollars with this. Because if we look at a test that can actually manage anemia, and that cost of a test is less than $2, we have the ability to do rapid screening. It's done in a CBC tube, the same time a CBC is being done. And this kind of test can prevent progression to iron deficiency anemia because it's an early marker. So many times anemia is underdiagnosed, it's underrecognized, and it's undertreated. And how often does a family physician send a patient in just to see what their hemoglobin is? They get a CBC as a starting point on these patients. And here we have a direct measurement that we can screen for iron deficiency rapidly and do a rapid intervention for these patients, which then improves their outcomes and enhances patient care management. And to show you an example from how the clinical effectiveness of RET-He can be used, and this is particularly in the selected population of cancer patients. This is from Dr. Persky. It's a recent publication from 2014, and they examined the use of reticulocyte hemoglobin to rule out iron deficiency as defined from iron studies. So these are patients who were presenting, had a CBC drawn, and they were also being followed up and checked for hemoglobin gammopathies, also for their iron deficiency by using iron, by using ferritin and transferrin saturation. So that's how they defined their anemia, by using transferrin saturation that was less than 20, iron less than 40, and their ferritin less than 100. And as I said, this was in a population of cancer patients who suffer significantly because of chemotherapy radiation treatment with acute chronic iron deficiency anemia. And what they found was that they screened 209 patients using the RET-He, and what they found is that if their RET-He was less than 32 picograms, and their hemoglobin was less than 11, they had a 98% negative predictive value for those patients. And their N for the patients that were anemic was 43 out of the 209. And what that negative predictive value says is that if your reticulocyte hemoglobin is less than 32 picograms, and with their leverage the hemoglobin at 11, less than 11, that means that 98% of the time the patient did not have iron deficiency, and biochemical tests would not be necessary. And so what they actually found is that by leveraging the negative predictive value, which is actually 10% higher than just using the hemoglobin and an MCV together, the negative predictive value of those two are 88.5%. So you see with the reticulocyte hemoglobin, one test included in CBC, 98% negative predictive value. And what they found is that they could decrease the number of iron tests that they were doing biochemically by 80%, which then translated to now having a very rapid algorithm for ruling out iron deficiency. They were able to reduce unnecessary tests, and we're all involved today in test utilization, right test for the right patient, and choosing wisely. And it equated to a large cost savings to the healthcare system and also to the laboratory budget. So what you see here is that when we're increasing effectiveness and we're increasing the value of laboratory information, we're able to do that by rapid turnaround time, rapid diagnosis, reducing costs because we're not doing unnecessary testing, and it's a win-win for everyone. And some of the recognition that we've seen in our institution is clinicians recognizing what the laboratory can contribute. And this is our CMO, and she says one of the hospital's top priorities is to eliminate, this was hospital-acquired infections. We also want to reduce patients' length of stay, but we also want to enhance patient safety. By delivering critical actionable information rapidly, the laboratory can help us achieve these goals. And we use our hospital-acquired infection program. Our rapid screening and reporting program is one great example of that. So what have we been able to do from the laboratory to improve organizational performance? Well, we think that we've been able to improve and provide best practices in providing rapid information so that we avoid readmissions, which is a penalty from CMS. We've been able to increase the effectiveness of efficiency of the organization by having better bed flow from our emergency. By returning a CBC in 14 minutes, the physician can make a quick decision about what to do, whether a patient's admitted, not admitted, what appropriate level of care is needed. We've also been able to enhance our patient safety. All of our instrumentation today, think about it, has barcodes on it. We have complete mapping and tracking of our samples today. And we're now very concerned about avoiding CMS penalties in 2015 and certainly more penalties in 2016. And we've been able to avoid those penalties. We've also been able to have cost containment by contributing decreased costs from the laboratory. And so what has the laboratory been able to achieve by leveraging technology and providing rapid tests? Well, the technology has actually been able to allow us to decrease our labor. And our labor costs, and this has really been over a decade, our labor costs are no more than 32% of the total operating expense. Typically, that's anywhere from 50 to 60% and can even be higher. But for us, it's anywhere from 32 to 35% in a year. We've been able to decrease our turnaround time, like I showed you, 56% just for CBC. And we've been able to decrease any delays in turnaround time. The number one malpractice suit for a clinical hospital laboratory is delay in turnaround time based upon diagnosis and treatment of the patient. We've been able to improve our productivity. We have 5 medical technologists that are working on our core floor. Basically, they're performing all the tests that lead up to that total volume of 2.4 million tests a year. And we believe that we've been able to enhance our quality. And we've been able to show others beyond the laboratory that we have increasing clinical effectiveness beyond the laboratory walls. So our quality is important to us. But maybe most importantly, what have we been able to achieve for our patients we serve every day and why we come to work? While we've been able to decrease our complications with rapid information, think of other things. Even a person who has anemia, has a very low hemoglobin, we're able to turn that CBC around in 14 minutes. We're able to report a RET-He. So we've been able to enhance our patient satisfaction with our patients, and we see that on our Press-Ganey scores that come back to us. Patients have a choice today where they get their health care. They can look up and compare hospital to hospital, and where do you want to get your care? You want it at the best hospital possible, don't you? And we also want to have a very good, excellent patient safety record. For the second time, we've received a score from Leapfrog for patient safety of A. And we're very proud of that. And so what are some of the keys for success? As far as laboratorians demonstrating our value beyond the laboratory walls, we need to demonstrate our knowledge. Who better knows our tests? Who better knows the limitations and the strengths of our tests than us? It's not the doctor, it's not the nurse, it's us. We have that information. We also want to network. And I do that by being on many different committees, and I'll tell you about some of those committees when I say attend a committee. We're also looking for opportunities to talk about the laboratory. We want to capture informal ones, sometimes just in the hallway. Our CEO is passing, and we'll say hi, and he'll say, hey, how's it going? I take that opportunity to say, oh, well, we just implemented this. We just upgraded our hematology. We've decreased our turnaround time by 56%. Now I've got his ear. He's starting to talk to me. Also, those formal opportunities. I've done grand rounds at our facility. I've talked in other venues that were more formal, like this. We've assembled teams. We've attended committee meetings. Committee meetings for us include, think about it, are you on critical care? Are you at a cardiology section meeting? Are you on transfusion, oncology section meetings? There are many meetings, critical care, infection prevention. So you want to become a liaison, and we want to capitalize on anything that you're currently doing. Do you have a LabGram newsletter? Do you do fax blasts? We also are on Facebook. So think about social media. We're on Facebook. So sometimes we have to toot our own horn. We haven't done a very good job of it, but we need to show the value we bring. And our technology helps us to leverage that information that allows us then to go on and get more technology to improve patient care. So as I said, there has to be something in it for everyone, whether you're the patient, the CEO, the physician, the nurse, or the laboratorian. And so it has to be a win-win for everyone. And we all win and add value if we have rapid turnaround times, rapid diagnosis, cost savings or cost avoidance, and patient satisfaction and physician satisfaction. Key tenets of showing the clinical effectiveness of the laboratory beyond its walls. And with that, I'd like to conclude and say thank you for being here. It's been my pleasure to share my story with you. I'll be happy to answer any questions for you. Thank you.
Any questions for Dr. Geiger?
Wow, thank you. I guess I delivered a very clear message, how important we are. And I want you to go home and tell everyone else how important we are. Do you know that technology is so important? It's an added thing is it helped us to recruit and retain our medical technologists. The average age of a medical technologist in my laboratory is in their 40s, their early 40s. They're not 55, the average age of a medical technology, and you can see that in some of the photos that I showed you. We have a very young, in comparison, medical technology force, and they like being in a high-tech environment and in some of the activities and the new tests that we've been able to bring in and leverage for better patient care. It's very exciting.
Don't forget to toot your own horn.
Boop, boop.
Thank
Thank
you.
you.